Today, our topic is overcome complex coronary interventions with the Novel Alveo 0.75 CTO Balloon. We are very honored to invite four respected professors from Lebanon and Poland. They are Dr. Trouble Name, Dr. Vasim Shatir, Dr. Jan Kruger, Dr. GRZEGORZ from Poland. Welcome. Then we will go for the final topic is the external crash in CTO RCA from Dr. GRZEGORZ. Welcome.
Welcome. Hello again. Can you see my slides?
Yes.
Yes, everything is correct, yeah.
Okay, so thank you for the invitation. I'd like to present the case of PCI of right coronary artery chronic total occlusion with use of external crash. So this is clinical presentation of the patient. It was 60 years old male with CCS class 2 post-CABG, diabetic with hypertension, but with good ejection fraction and only kinesis of the basal segment of inferior wall. And this is contralateral injection. We had CTO of Complex RCA with flow from antegrade collateral, diseased distal vessel. As you can see from left system, rather not good septal and epicardial connection. So in JCTO score, it's 3 points for ambiguous gap calcifications and length of occlusion, but even 6 points in progress CTO risk of complication scale. So we started with antegrade wire escalation, but it was unsuccessful, and very fast we changed strategy for antegrade dissection and reentry. And you can appreciate here Stingray balloon, and we hoped to perform stick and drive technique in mid RCA segment, but it was unsuccessful as well, as you can see. So we changed strategy for retrograde, and because of angle of septal, we inflated balloon in LAD to progress with microcatheter to septal. And then we performed surfing, tip injections, but we did not find any connection. As you can see. So we changed strategy for epicardial. This is tip injection from epicardial from circumflex. This is tip injection, and the epicardial seemed not to be too promising, but it was possible to pass with SUOH and wire and Carvel microcatheter. In next stage, we performed reverse card in different places, and finally, it was possible to find good place, and as you can see on this slide, to progress with retrograde gladius to antegrade trapliner. But then we had a big problem with retrograde microcatheter stop due to calcifications in distal segment of right coronary artery. So we performed tip in, as you can see here, and we progress antegrade microcatheter on retrograde wire, and then progress antegrade microcatheter to the distal RCA through the body of CTO, and then change for antegrade wire from antegrade microcatheter and wire the vessel. We were very happy and almost successful, but almost, because then we had an uncrossable lesion. In the same place, we had a problem with retrograde microcatheter progress due to calcifications. It was no possibility of rotowire passage. So one option was out. So first we performed granuloplasty to change proximal segment, proximal uncrossable lesion, proximal fragment of this uncrossable lesion, but it was no effect, only dissection. So then we changed strategy for external crash. So we inflated balloon 1-to-1 to vessel in subintimal, or as you can say, extra plug space, and crash this uncrossable lesion from outer. And after it was possible to pass the uncrossable lesion with a very small CTO dedicated balloon Alveo 0.75. And then we performed, of course, predilatation, as you can see, stenting. And this is the final result. So in conclusions, external crash is a very valuable option in CTO or in a crossable lesion, especially in case you cannot use rotablation or orbital atherectomy. And another possible option is external lithotripsy, so lithotripsy from subintimal space. And Alveo, very small and dedicated to CTO balloon 0.75 is really our friend and very useful, our low profile balloon that can be used in cases like this. Thank you very much for your attention.
Thank you. Thank you for Dr. GRZEGORZ showing us a really challenging and complex case. And now any question or topic need to discuss?
Thank you, doctor, for this wonderful case.
Yeah.
It's interesting indeed how you modified the lesion by crushing it from the subintimal space. So this space was, I think, used before for the rendezvous, correct?
Yeah, before I used for antegrade dissection and re-entry, and then after I go further with knuckle, and then with balloon, and it was no resistance, so I can progress with balloon to perform external crash.
So do you? So with when you fail a CTO crossing dedicated balloon, what do you usually use? Tornus, Corsair? What do you have on your shelf? What do you?
Yeah. I think this is the great question, and because this is the topic of our meeting, because. From my previous presenter, great lecture, we have many possibilities, of course, but we must remember that in uncrossable lesion or in CTO lesion, the best, the fastest, the simple way when we have wired the vessel is just go with small balloon, and this is the best solution. And I think Alveo is very useful because we have a problem from the last years with the very small balloon like this to pass the lesion. And of course, we have other options. As we can see, we can go first with balloon. Normally, I go first with a very small balloon, and even if I cannot cross the lesion, I inflate the balloon and hope that proximal cap will be modified a little, and then it can be possible to go even with inflated balloon, and sometimes it happened. If not, I use sometimes, of course, if it's possible to go with microcatheter. Like first I tried the microcatheter like Corsair, and then of course if it's not going, you can use Tornus or Turnpike Gold, and then try it with balloon. If it's not working, of course, it's always possibility to go with rotawire and try rotablation, or try orbital atherectomy. If it's not working, sometimes I use granuloplasty, and sometimes it's working, of course, but we must know that the complication can be, of course, very big dissection and perforation. And I think if it's not working, external crash is a quite good solution. And another thing I must try, I never tried, I have never seen the case with this, but only one heard about its possible usage. It's external lithotripsy. I don't know if it's safe, but we must try and progress with our equipment. Yeah.
Yes, indeed. Thank you very much. If I may add, we can always, after for us not to lose the wire, we can use a crossbus if you have it on the shelf with like manual rotablation with crossbus. So we used it in a couple of patients, and we presented them in NeuroPCR. It was really a success. So
it's very good option, of course.
Yeah. Or the crosser system. Do you have the crosser system?
Excuse me?
There's a crosser.
Crossbus?
No, crosser. CROSSER, crosser system. So it's a ultra wave emissions. It's like a balloon catheter that emits some waves, and it.
You mean lithotripsy or something different?
No, something different. Yes,
something different. I don't have.
Yeah, that's. So I always try to use the CTO high pressure balloon to modify the lesion, to do with it granuloplasty, and I think modifying the lesion either with the crush technique or with the balloon that we have on the shelf, especially if you have it a high pressure balloon like you did, is excellent.
Thank you.
Okay, and thanks for the excellent presentation. And I see one question from Edward. Is antegrade approach always first used before the retrograde in CTO cases? If not, what are the main considerations for going retrograde directly?
I think my philosophy is that even if you are going retrograde directly, first it's a first line strategy. You must have antegrade to perform reverse cart after. Of course, if you have osteal lesions like sometimes right coronary osteal lesions, right coronary osteal CTO, then we have a problem with antegrade progress. So this is evidently the retrograde case, but normally I always start antegrade wiring. And for me, sometimes the best option is, if it's possible, if you have good distal vessel, to try first with antegrade dissection and re-entry, because we have orbital, we have a CTO algorithm now that we must use all three methods: antegrade, wiring, ADR, and retrograde. And if we are using these three methods, we can follow and solve most of cases. If only one or two, it's the results are worse. And one thing about ADR is that the ADR is rather safe, because most of complications in CTO are connected with retrograde, to say the truth.
Okay. Thank you. Thank you for the explanation.
Thank you very much.
Thank you, Dr. Impressive. Thank you.
Yeah.
Thank you, Dr. GRZEGORZ, for the presentation. I just have one question, yeah, because you are really experienced person, doctor with various small tip profile CTO balloons. Can you see any advantages in relation to Alveo?
Yes, to say the truth, I tried Alveo several times, and I don't expect a result like this. So I'm very pleasantly astonished with this balloon. And of course, I should not now mention the name of other film balloons, but it was balloon like Tazuna from Terumo. And I missed this balloon very much because the next generation balloon is in Terumo is completely different. And I think the whole CTO society is missing this balloon, but it's no more. I think this is a space for Alveo, to say the truth, to replace this balloon, because from my case, from last month, I have 2 or 3 cases. And this balloon was better, for example, from Uray 1-0, and Uray couldn't go, and Alveo did. So I think it's a very useful equipment for us.
Thank you very much.
Thank you.
Okay. Any questions from the audience?
Dr. Sobieszeek, I have a question. In retrograde approach, when you find it difficult to cross septal collaterals with microcatheter, is it possible to use a small CTO balloon like Alveo to dilate the collaterals to help cross with the microcatheter?
Yes, of course, the Alveo is a good option too, but I think in collaterals it can be 1.5 balloon and it's no problem. But normally when I have a problem with collaterals crossing, with septal collaterals crossing, I change the microcatheter, for example, from Corsair on Corsair Pro X. XS. If it's not working, another thing that is very good, it's daughter channel. So instead of using 150 centimeter, for example, Corsair, you can use another 135 centimeter, so shorter. And sometimes it's like that you can cross with shorter. Take it away and then go with longer that did not want to pass before, and it's working. Of course, you can use guide extension and donor artery, and one option is as well to perform balloon predilatation of septals. I think Alveo can have another usage because there is a method like CART. So you must go from donor artery through septals and go to the distal cap retrogradely with balloon. Of course, it's not used very often, it's rather, but it's possible. And sometimes it can be option, just not reverse card. And then when you do like this, you can go with integrate wire and wire the vessel. So I think Alveo can be used very efficiently to this card technique, first of all.
Got it. Thank you, doctor. It's very educative.
Thank you, Doctor. Yes. Okay, and the improvements in the technique and dedicated devices for CTO PCI, we need to combine with advanced in procedural strategy and have resulted in a dramatic increase in the procedure success. Hello, can somebody mute? Hello. Yeah, and thanks for our experts and all the audience again. And for more information, you can search BrosMed medical website. And any question, you also can contact us via email sales@brosmed.com. Thank you.